Here's a board favorite. A patient's blood smear shows a granulocyte with a bilobed nucleus and bright pink-orange granules. Which cytokine made it? If your answer wasn't IL-5, you just missed a guaranteed USMLE point. In this video, we'll cover where blood cells come from, how lymphoid and myeloid lineages split, what each white blood cell looks like and does, B, T, and NK lymphocytes, the WBC differential, and the clinical pearls tied to all of it. I'll flag the timestamps in the description below if you want to jump straight to one. Let's start right where every one of these cells begins, a single stem cell tucked inside your bone marrow, and the long journey it takes to become everything from a neutrophil to a natural killer cell. So what exactly is hematopoiesis? It's the lifelong process your body uses to make blood cells. Every red cell, platelet, and white cell you have traces back to one type of cell, the multipotent hematopoietic stem cell, or HSC. But where that happens changes as you develop. In the embryo, during the first few weeks, it's the yolk sac doing the work. As the fetus grows, the job shifts to the liver and spleen. And by adulthood, it's settled permanently into the bone marrow, specifically the axial skeleton and the proximal long bones. That progression, yolk sac to liver and spleen to bone marrow, is worth memorizing on its own. Because when bone marrow gets crowded out by disease, the body can actually reactivate the liver and spleen to make blood again, extramedullary hematopoiesis. And this developmental sequence is exactly why that makes sense. Now that we've covered where hematopoiesis happens, let's look at how one stem cell becomes an entire blood system. HSCs divide asymmetrically. One daughter cell stays behind as a fresh stem cell. That's self-renewal, so the supply never runs out. The other daughter commits to a lineage, becoming either a common lymphoid progenitor or a common myeloid progenitor. Which path it takes isn't random. It's directed by cytokines and growth factors, stem cell factor, thrombopoietin, IL-3, and GM-CSF. In other words, cytokines steer differentiation, and that single idea is the thread connecting almost every immune cell you're about to meet. With that in mind, let's split the tree into its two branches. Text lymphoid versus myeloid draws in, on one side, the common lymphoid progenitor. It gives rise to B lymphocytes, which mature right here in the bone marrow, T lymphocytes, which migrate out to the thymus to mature, and natural killer cells. B and T cells are adaptive. They mount antigen-specific responses, while NK cells work in an innate, non-specific way. On the other side, the common myeloid progenitor produces everything else: erythrocytes, megakaryocytes that make platelets, the three granulocytes, monocytes and macrophages, dendritic cells, and mast cells. This whole branch is innate, which is why myeloid cells perform rapid, stereotyped responses like phagocytosis and inflammation, rather than the targeted response B and T cells build over time. Building on that split, here's a shortcut worth locking in before test day. Lymphoid gives lymphocytes, B, T, and NK. Think L4L. Myeloid gives everything else: red cells, platelets, granulocytes, monocytes, and dendritic cells. It's a small rhyme, but say it out loud a couple of times. It'll save you seconds on test day when a question asks you to place a cell in the right lineage. Next, let's put faces to all these names. Morphology is exactly how you'll identify these cells on a smear or an exam image. Start with the neutrophil. Segmented, 3 to 5 lobes, pale pink granules, and it's your first responder against extracellular bacteria and fungi. The eosinophil has a bilobed nucleus with large pink-orange granules, built for helminth defense and type 1 hypersensitivity. The basophil looks similar but bilobed and packed with deep blue granules, releasing histamine and heparin in allergic reactions. The monocyte has that classic kidney-shaped nucleus and no granules. It's the circulating precursor to macrophages and dendritic cells. Once it's in tissue, It becomes a macrophage, ruffled membrane, vacuoles, irregular shape, phagocytosing and presenting antigen. And the dendritic cell is unmistakable, stellate, finger-like projections, which is exactly why it's the professional antigen-presenting cell bridging innate and adaptive immunity. As a high-yield finishing point, remember the surface markers. CD19, 20, and 21 mark B cells. CD3 marks all T cells with CD4 and CD8 splitting helper from cytotoxic, and CD16 and CD56 mark NK cells. So where does that leave the lymphocytes themselves? Let's look at each one individually. B lymphocytes mature in the bone marrow and express surface immunoglobulin, their B cell receptor. Once activated, they differentiate into plasma cells, which is exactly how antibodies get made. T lymphocytes are different. Their progenitor leaves the marrow and migrates to the thymus, where it undergoes positive and negative selection. Their T cell receptor recognizes peptide bound to MHC, and they split into CD4, positive helper cells, and CD8, positive cytotoxic T cells. NK cells are large granular lymphocytes that recognize cells with down-regulated MHC class I or stress ligands. And here's the catch. Unlike B and T cells, they don't rearrange their receptors at all. So how do B and T cells get such enormous receptor diversity in the first place? It comes from somatic recombination, V, D, and J gene segments joining together in new combinations. This matters because it's the defining line between adaptive and innate lymphocytes. B and T cells generate diversity through somatic V, D, J recombination, while NK cells rely entirely on germline-encoded receptors. Quick check before we move on. Which lymphocyte kills using perforin and granzyme without ever rearranging its receptors? You just covered this a minute ago. Drop your answer in the comments before I tell you. Let's keep going and look at how these cells show up on an actual lab report. Now, let's turn this into something you'll actually see on a lab report, the WBC Differential. Laboratory evaluation reports both absolute and relative counts, and shifts in these proportions point you toward infection, allergy, or a hematologic disorder. Neutrophils normally make up 50 to 70% of your white count. Text bands 0 to 5% draws in, with immature band cells staying under 5%. Lymphocytes run 20 to 40%, and monocytes, eosinophils, and basophils fill out the rest at 5 to 10, 0 to 5, and under 1% respectively. Here's why memorizing the numbers matters. A shift above range tells you something specific. Neutrophilia points to bacterial infection, lymphocytosis points to viral infection or pertussis. And eosinophilia points to parasites or allergy, while basophilia is your red flag for a myeloproliferative disorder. So, where does that leave the finer clinical details that tend to show up as exam distractors? Start with the plasma cell. Eccentrically placed nucleus, prominent Golgi, packed with antibodies. It's simply a terminally differentiated B lymphocyte, built as an antibody factory. The dendritic cell, meanwhile, is the most potent antigen-presenting cell in the body. It expresses MHC class II along with co-stimulatory molecules, which is what lets it activate T cells so efficiently. Now here's a pair that gets mixed up constantly: mast cells and basophils. Mast cells stay resident in tissue, while basophils circulate in the blood. But here's the catch. Both of them release histamine, so the distinguishing feature isn't their function, it's simply where you find them. Building on that idea of distinguishing features, let's close the loop on two more cells worth double-checking before an exam. First, a quick recap on NK cells. Text: NK cell lacks CD3 draws in. They lack CD3, which is the marker every T cell carries. And as we covered, they never rearrange their antigen receptors, which is exactly why they're classified as innate immunity, not adaptive. Then there's the macrophage, which simply arises from a circulating monocyte once it settles into tissue. In the brain, it's called microglia. In the liver, Kupffer cells, and in the lung, alveolar macrophages. In other words, these aren't different cell types at all. It's the same macrophage wearing a different tissue-specific name, depending on where it lives. Here's where we bring back the exact scenario from the opening of this video. Which cytokine differentiates the myeloid stem cell into a granulocyte with a bilobed nucleus and pink cytoplasmic granules? Your options: IL-11, IL-5, thrombopoietin, GM-CSF, and IL-3 together, or IL-7. Take a second to commit to an answer. The answer is B, IL-5. It's the cytokine that specifically promotes eosinophil differentiation, which is exactly why the description matches. Bilobed nucleus, pink granules. The distractors are testing whether you know the difference. GM-CSF and IL-3 are early, broad myeloid growth factors acting further upstream. And IL-7 drives lymphoid progenitors instead, which is why it doesn't belong here at all. So, let's pull all of that into one clean recap you can run through right before your exam. Eosinophils are driven by IL-5, bilobed nucleus, pink granules. Basophils are driven by IL-3, also bilobed, but blue granules instead. And neutrophils are driven by GCSF, with that multilobed nucleus you'd recognize anywhere. Notice the pattern: one cytokine, one cell, one look. Lock that triad in, because this is exactly the kind of last-minute exam tip that turns a guess into a guaranteed point. So, where does that leave us? You now know exactly where every one of your blood cells comes from, how the lymphoid and myeloid lineages split, what each white blood cell looks like and does, the biology behind B, T, and NK lymphocytes, and how to read a differential and its clinical correlates. And if you remember nothing else, L is for lymphoid, giving you lymphocytes, M is for myeloid, giving you everything else. Good luck on your exam. Thanks for watching.